I'm seeing so many patients with these really refractory UTIs who have all those symptoms of estrogen deficiency. I'm keenly looking for POI.
Hi, welcome back to the Live UTI Free channel. My name is Melissa, and this is a follow-up interview with Dr. Tim Hlavinka. After our last interview with Dr. Hlavinka, we received many questions about the role of hormones in contributing to recurrent UTI pre-menopause. So in part one, we'll discuss primary ovarian insufficiency, or POI, which occurs when the ovaries stop functioning as they should before the age of 40. POI and recurrent UTI may be linked. If you haven't seen our first interview with Dr. Hlavinka, check it out. If you enjoy these videos, think they're important, and want to support what we do, don't forget to subscribe and tick the bell so you'll be notified of our new content. Thanks again for joining us on this journey to making change in women's health. Today, I'm joined by Dr. Tim Hlavinka for a follow-up interview. Dr. Hlavinka is a urologist as well as being an expert in sexual health and women's health. He has an extensive background in providing support to recurrent and chronic UTI patients and is very active in our community. So thank you once again for joining us to answer the questions that we've gathered from our audience.
Of course, I'm more than glad to do so, Melissa. Thank you for everything you do for the community. You're instrumental in getting my message out to all the patients I've helped over the years. And I cannot imagine that the community and the world is not a better place without your activities. And we all thank you, I'm sure. So,
Well, that's very kind of you to say. And I think we
it's accurate.
organized
It's accurate.
we organized this interview because we had some follow-up information that we wanted to share.
Mm-hmm.
So I want to jump straight
Mm-hmm.
into the topic of primary ovarian insufficiency, or POI, and it's also called premature ovarian failure. So it would be a great place to start if you can explain what those terms mean.
Uh, so this is a condition that has been known for a long time and had several health uh, conditions, diseases, genetic abnormalities, for which it was well recognized and quite uh, understanded understood to the mainstream medical community. Any primary care or OB-GYN knew how to diagnose this based on those. And I'm not going to go into those because you can Google that and you can see what those causes are. But for practical purposes for our community and for the patients I see, this is almost solely due to hormonal contraceptive use. And it is something that's been recognized for a long time in research on sexual issues, particularly libido. And because of that, there is a new genetic marker that's being developed that actually looks at variations, genetic variations in the androgen receptor in women that predispose them. And about 7% of women worldwide have this androgen receptor abnormality, which means 1 out of every 14 women is predisposed to having this happen. Now, why have we not done more work on the estrogen receptor, which it would seem like that would be the more fruitful avenue? Well, quite honestly, the clinical trial with 25 patients with the control group was an OB-GYN, Andrew Goldstein, who's a genius, who was seeing women for low libido due to the pill. And because of that, it seemed more fruitful to go down the androgen receptor to look for abnormalities. And that's quite simply just sort of the aha moment that led to this. The good news is that he has exposed us, the medical community in the world, since our organization is international, to this incidence. I will say that at the Women's Health meeting 3 years ago, 4 years ago, there was a single abstract presented that kind of introduced the possibility of this being more important than we knew. The next year, there was a panel with a discussion with 3 or 4 lecturers. And the following year, there was half a day spent on this. So the, the a way to determine if the women's health medical community and organization, professional organization, is proactive about these issues is to see how rapidly they adopt these new diagnostic algorithms to see whether or not this is causative or potentially causative for you. And my recognition of this is just basically a perfect storm from seeing a lot of women for sexual dysfunction from oral contraceptive use, but really any hormonal contraception can do it for any length of time. I think Dr. Goldstein found that contraceptive use for as short as 6 months at any time in your life, even if you've been off them for years, can predispose you to this. So there's something that must happen to alter that receptor permanently in a number of women. Now, I don't have a handle on how many of those versus the ones who can easily reverse it. We'll get into that more in a minute. But the bottom line is that this is something that for my practice, I have to look for it because I'm seeing so many patients with these really refractory UTIs who have all those symptoms of estrogen deficiency, and estrogen and replacement is helping them. So I'm keenly looking for POI, and I think POF is a overkill. I mean, you want to give women hope that if they have this, it's insufficiency, it's not failure, because failure typically means that you're not going to recover. Now, is that to say that in some patients it's not recoverable? Again, we'll go into that in more detail in a minute, but for 98% of them, they can recover ovarian function. And I think we're going to go through a few sort of scenarios in a moment. But that's why POI is so important. And another contributing factor is COVID. There was a study that showed 6% of women, even 6% of women, asymptomatic, who either had mild or zero symptoms with their COVID, but were diagnosed positive, antigen positive on the PCR test, had ovarian, attacked their ovaries and caused premature ovarian insufficiency. Now, this is recoverable again as well, but there's not a lot of time to study after this. So I don't know if I'm saying all those women or if I'm convinced it's the perfect storm of stress, Western diet, COVID, and oral contraceptions, hormonal contraception, I should say, hormonal contraception. That is sort of a perfect storm that's led these patients to me that show that they're sort of the infections, both I call them genitourinary infections now. They become a marker basically for POI and sort of a clinical sign. So yeah, that was a long answer, but I think a critical answer to how important this is, and I'm seeing it all the time now, all the time.
Are you seeing symptoms of POA in very young patients that are similar to those symptoms experienced during menopause?
Absolutely. I used to say my youngest patient was 21. Now I can't say that because I have a teen, a 17-year-old, whose mommy started her on contraceptives. I'm sorry, parents. I shouldn't say mommies because that's not always women that start them. It's a parental decision at age 12 because she started her period at age 11. So at 17, she's in sort of not full-blown menopause, but definitely ovarian insufficiency. It's not at all uncommon to see women in their mid-20s now with this. It used to be, we kept ratcheting down the age group. We would see patients in their mid-30s, early 30s, and those didn't raise an eyebrow. Now, quite honestly, patients in their 20s don't raise an eyebrow in my clinic. They're just sort of become part of what we do to determine what might be causative.
Can you tell us more about the link that you've seen between POI and recurrent UTI and how common you think POI is as a cause for recurrent UTI in younger people?
It is so important right now that any woman of any age with refractory UTIs is considered to be POI until proven otherwise. And because it's mainly a clinical diagnosis, and we'll get into the sort of other tests that you could do, but since it is a clinical diagnosis, it's important to make sure that you suspect it. And obviously I am now all the time. And then you test for it. But if you suspect it, even if tests don't corroborate, then you treat. And that's the most important thing because these young women are acting for all intents and purposes as they have a hormonal deficiency, and typically it's an estrogen deficiency. And estrogen replacement, be that either topical or systemic, is what's required to solve the problem. Um, there is a group of patients for whom I suspected. I am never able to prove it because they don't really have any signs or symptoms other than the fact that they can't get rid of their UTIs. And I sort of treat them accordingly at this point, and see what the outcome is.
So how do you test for POI?
Clinical suspicion, and physical exam. Very, very important to do a physical exam. So many young women come in, and there's no way that a provider would suspect that they have any signs of estrogen deficiency because they look so estrogen replete everywhere else. But without doing a very careful pelvic exam, including, most important thing is visual inspection and tactile contact with the tissues to see the tissue character, and to see whether or not there are signs of menopausal changes, otherwise known as genital urinary syndrome of menopause, GSM for short, so we won't have to spend hours saying that word. But seeing signs of GSM in these very young patients, which they almost all have, Melissa. I will tell you, if you look carefully, even it's something as subtle as vaginal dryness, a thin epithelial layer, loss of the rugae, the sort of the coarse wrinkles in the vagina, atrophy of the labia. All these things can be signs of estrogen deficiency, but you got to look for it. And most of them, it's pretty obvious, unfortunately, and others have missed that. Then we do labs. Labs don't have to be confirmed. I try to do labs at a certain time of their cycle if they're cycling. If they're not cycling, you just do random labs and see. You rarely get the full-blown elevated FSH and LH that classically is a test for menopause. But what you can see is subtle abnormalities in the hormonal pattern. Occasionally, you have to do like a luteal phase and a ovulatory phase to be able to see. I'm sorry, ovulatory phase and a follicular phase. Excuse me, to see whether or not there's subtle differences, and that's diagnostic, because you should have in a normal menstruating woman, you should have fairly wide swings in hormonal levels. And if they don't vary, that's one thing. But really, even subtle abnormalities like an elevated SHBG or just a slight free testosterone, decrease in borderline low free testosterone, an estradiol that really doesn't do much, sort of a blunted ovulatory peak of estradiol and testosterone. Things that I've looked at over the years that I suspect from this, and any hormone abnormality at any time during the cycle is pretty much in my clinic diagnostic of POI. Now, there is some research into something like anti-Mullerian hormone that's not widely available. I'm looking into start using that. I honestly think that's the way to go because it seems to be more sensitive. Inhibin B, these are lab tests known to the fertility specialists, and they've been looking at these for years, but they do seem to be adequate markers for I should say, very, very precise markers for potential POI. I'm looking into using these, but just so I can be complete and tell your clients state of the art information, those are things that their provider might suggest, and I'm looking into getting those.
Speaking of fertility, is POI something that impacts fertility or the ability to conceive and pregnancy itself?
Absolutely. Many of these patients are seeing fertility specialists. So many of the young ones, pregnancy is not a consideration. So I'm not going to say it's a very frequent issue, but definitely I've seen a lot of patients for infertility, and unfortunately, sometimes it's not something. How should I say this? if they can't have intercourse, they have so much vaginal dryness and atrophy that
Mm.
you can't even get your pinky digit in for the pelvic exam. Pretty obvious why they're not getting pregnant. So I just recently had a 25-year-old who was like that, who had seen 6 gynecologists and a fertility specialist who I don't know what they were seeing on exam, but it was obvious to me as soon as I pulled back the drape, and I didn't even need to do an exam. Um,
Mm-hmm.
she's thankfully better. So
So when you do identify a POI, what is your approach to treatment?
it depends upon the patient's clinical presentation.
Mm-hmm.
I typically treat the most severe symptoms. Most of the time, they're multiple. It would be something like infertility, recurrent UTIs, vaginal dryness, pain on intercourse. Um, Typically, that's how the patients present. So you get sort of a multifactorial treatment. This young lady, I sent her to the pelvic floor physical therapist after a few weeks of aggressive intravaginal hormones. It was pretty clear that she was not going to respond quickly. So because she also had hot flashes, night sweats, all of that. She was in menopause, and
Mm-hmm.
6 gynecologists and a fertility doc could hear those symptoms and look at her exam and not put the two together is quite frankly appalling. And I ain't that smart, as we say in Texas. But you know, it was there. It was there. It was obvious. So my point being is, I treat them very aggressively. If they have lots of symptoms like she does, and really I think I need to jump on it, I'll start them on systemic hormones, um, and then obviously very aggressive intravaginal hormones, and sometimes labial hormones if they need those as well, which she did. And thankfully, within 18 months, she started cycling again. I weaned her off the hormones, and she's pregnant now. So I'll
Amazing.
do a back on that one.
How does that type
So
of
yeah.
systemic hormone treatment differ from a birth control pill?
So what I do is it's actually much. So a birth control is, and this is of course the yin yang um, uh, of oral contraception and any hormonal contraception, but oral is the worst because of how it impacts our liver metabolism of hormones and affects the ovarian and adrenal production. So the the bottom line is that when you take an oral hormone, it's just the tiniest amount of estrogen and progesterone to regular and stop you from ovulating. So in many women, that's okay. They do okay. But all oral contraceptions, even the very low dose E plus P alone, or even just the low estradiol pills, they tell your body you got enough, just the right amount, so you don't ovulate. But for many women, that's not enough systemically or in local terms. I have seen mid 20s young woman with osteopenia, and she didn't even have a family history of bone density issues. So I think it's the receptors, and we'll get into that in a little bit more about why I think this is happening. But for me, that's the diagnosis, and that's the problem with the pill. Quite honestly, is
Mm-hmm.
it sort of um, achieves its goals by fooling your body in a way that's not healthy for many women.
Mm-hmm. So when someone starts on POA treatment, how long does it usually take for them to respond?
It typically, there's very little response for several months, which is very frustrating for the patients because they want some instant results. And I understand that. And I tell them it's going to take potentially 18 to 24 months to get back to normal. Um, this lady responded in about 14 months and was pregnant at 18 months. So I'm thrilled about that. But it's not a short term. Now, there are those that say I should be using HCG, which is their fertility injection, but it's just so expensive, and it's like $2,000 for a
Mm-hmm.
6 week course of it, and you might need it for a year and a half. So it's that's and there are some discounted compounding pharmacies that make HCG, and I'm considering that in the most severe cases. But then Then you get into sort of what's the term for that? Hyper multiple pregnancies, multiple
Mm-hmm.
pregnancies. So that's the issue with using HCG. So I
Mm-hmm.
like the way I do it because it gives the patient what they need at first just to make their symptoms better. And
Mm-hmm.
then, for the majority of them, I'd say 90% of them, Melissa, they do return to function eventually. Could I get them back sooner with HCG? Well, I typically have reserved that for the ones that haven't responded to the regimen that I'm using.
Mm-hmm.
And then that gives me sort of that salvage potential, telling them, look, you got to spend, $8,000, $10,000 because there's nothing else we can do.
Mm-hmm. And do you typically recommend that treatment for POA continues into pregnancy?
The problem is that we don't know what it's going to do to the pregnancy, so it pretty much has to stop.
Mm-hmm.
I do most of the time convince the obstetricians to let them at least continue the vaginal DHEA if they're on that. I will say that when the estradiol level starts to peak, like at about the second trimester, most of them get better. Now, sometimes they don't completely get rid of their UTIs,
Mm-hmm.
unfortunately. But the other menopausal symptoms obviously improve simply because the systemic estradiol levels are very high. They can be 5,000 at peak in pregnancy.
So is this kind of treatment you're talking about people improving once they're on treatment? Is there a point where they can stop treatment forever and their body will then recommence producing what it needs to?
Yes, yes. I don't really have a handle on a percentage of that, but it's a fairly high percentage. Many of them do have to continue vaginal estrogen treatments. It's almost like once the receptors have been um, upset because there's not enough hormone circulating that they like to grab onto and do their
Mm-hmm.
tissue health. Sometimes it's lifelong. Sometimes it can be intermittent, like they need to use it 3 months a year, and that's all they need. Uh, Quite variable in terms of that. Uh,
Okay. And this topic does come up quite a bit in our community because it's not something that clinicians tend to do, treat women in their 20s and 30s with hormonal replacement therapy or vaginal estrogen. Do you think it's safe for women at that age to use these types of treatments?
if I didn't have it, I'd have to quit. It is the single most effective thing I do is estrogen and topical estrogen and testosterone to the external genitalia. To me, there's so many cases of women for whom that has been game changing, and they're upset because 90 days later they're still getting infections, but then all of a sudden, once you get the vaginal epithelium to its healthy state, things really do turn around.
Mm-hmm.
So it's definitely safe, underutilized, and essential in my practice.
And are there other hormonal imbalances pre-menopause that can influence UTIs?
Mhm. Well, we know now that cystic ovarian disease can be endometriosis, all of those, which typically because of either the condition, the hormonal condition itself. And I need to correct sort of a common misconception out there among providers about PCOS. That, and this is my own, I thought polycystic ovary syndrome. Well, you got these big cysts on there, and they're causing no. It's actually they have multiple small cysts that are in various stages of the ovulatory cycle that are little independent hormone factories, and because they can produce pretty much anything they want, you can have all these imbalances. So the key with PCOS, in my view, is to treat what you're seeing what the symptoms of this libido or androgen hyper androgenism, hirsutism, facial hair, hair loss, things like that, libido. Treat the symptoms because you really don't know what sort of minor hormone factory those little cysts are doing. There are certain hypothyroidism, diabetes, like I said, COVID, pro-inflammatory conditions. There's a whole host of things that can cause this.
Do autoimmune diseases such as Hashimoto's limit the body's ability to fight UTIs?
I'm convinced that that's the case, simply because I see so many patients with autoimmune disease, connective tissue disease, rheumatoid arthritis, Sjogren's, it's lupus, patients on immunotherapy for those conditions. So to me, and if you talk to the functional medicine doctors, that's what they'll tell you. It's pretty much part. They treat it as systemic inflammation, and they feel like any inflammatory, even an infected tooth or a joint that's infected, or I mean that's an obvious case of it, or something like that. But any kind of chronic source of inflammation, um, dental caries, chronic sinus infections. These are the kinds of things over through the years I've seen this sort of commensurate. Somebody came in, one of my patients had a flare up of his sinusitis. He was going to come in for a flare up of his prostatitis. I could almost guarantee you. It just was just part and parcel. And it didn't, even before the antibiotics might have been started, that would have caused a resistant organism to emerge. So this is a pattern I learned early on. So the problem is that the immune system is pretty complex, and there are limited things that can be done from a improvement standpoint, but we should all be. Many of my patients are already doing that, quite honestly, Melissa. They're smart. They know that they've got to keep their immune systems healthy in order to fight this. But obviously, vitamin D, vitamin A, things like that, those are things that we can do to keep our immune system strong. Whether or not you take some other supplements, that's something that I don't really feel comfortable answering, because I rely on my functional medicine providers to do that for our patients, and they do an excellent job of evaluating and boosting the immune system.
And what about for patients that do have endometriosis or estrogen positive breast cancer? How would you treat them in the case of POI?
So I have been able to have almost all the breast cancer oncologists agree to give intravaginal hormones, depending upon what is their receptor status and things like that. And of course, their disease status. I mean, someone who's progressing, we wouldn't do this, but even some of them really demand it because their quality of life is so poor. And we measure estradiol levels. At first, I had to bring these poor ladies in every week to get an estradiol level to prove to the breast cancer oncologist that they were not having systemic elevations of their estradiol. And ultimately, they realized that that was never the case, that you can treat, and I use a dilute concentration, not the kind of typical 1 gram of a 0.1% solution. I typically use a lower 0.01 and about a quarter gram a week to and then we measure hormones to see measure estradiol levels to make sure they're not absorbing. So almost all of them would let me do that. Now, the cases where there's really concern, or if the patients do have systemic absorption, then almost all of them allow me to use intrarosa or intravaginal DHEA compounded. And quite honestly, at the last meeting I went to, and I'm looking forward to going next week to getting an update, there was pretty much equivalent to intravaginal estrogen, be that estriol, estradiol, combinations of that intravaginal DHEA is doing the same things to the epithelium at the same time, and to the same degree that the estrogens are. So that's a very exciting new finding.
And is intrarosa something that's available on prescription only?
Yes. Now I use a compounding pharmacy to make the intravaginal DHEA suppositories because I can use twice the concentration. I went to a presentation last year where the principal investigator was telling us how wonderful it is. I showed these slides of before and afters of vaginal epithelium biopsies, and these women's health providers were oohing and eyeing and all that stuff, and how much it had done to the woman's vaginal epithelium, how much benefit it had. And afterwards, I asked him as a sidebar, because I knew he would talk about it during the presentation. I said, well, it comes in 6.25, 12.5, and 25 micrograms. Did you decide why did you decide to come out with 6.25? He goes, well, we found they were all equivalent. It's like, right.
Mm-hmm.
No way. There's no way that 25 micrograms is going to be the same as 6.25 micrograms. So I use 12 and a half, mainly because of concerns about the production from the compounding pharmacies, and because I find that that works better than the 6.25.
Mm-hmm.
So that's what I typically do daily, 12.5 milligrams in intravaginal, intrarosa, I should say intravaginal, intrarosa. Sometimes doubling the dose can be effective if they can get a hold of intrarosa at reasonable prices. But 12.5 micrograms of DHEA vaginal suppository daily.
Okay. That's good information. But we talk a lot about estrogen to support frequent UTIs, but there are a number of people in our community that have reported that they only experience symptoms at times in their cycle when the estrogen would be higher. Do you have a theory for why that might happen for some people?
It's confounding. And to have a theory, yes, I have a theory. Do I have science behind that and research? No, because it's one of those clinical circumstances where you know that it's the hormonal flux that's causing the issue. And I see this and sort of discern this from the menopause patients, menopausal therapy patients that I have, where I can give us the same dose of a hormone replacement therapy month after month after month, and their variation in response is significant. Is that an absorption phenomenon? Well, I will tell you that I'm now giving injections for this to try to avoid the trauma of hormone pellets that a lot of patients are getting here in the U.S. And other places as well. That's very invasive. I always tell my patients before I'll do that for you, and the next time you go to your provider who's doing that for you, because I see a lot of these patients that aren't doing well, watch the YouTube training video I had to watch for it and see if you'll get the procedure done. Once you see what's being done to your backside, you won't go back. I will tell you that. It is really a brutal procedure. Now, it's effective and keeps a lot of women very satisfied for 12, 14 weeks, and I get that. But I'm doing the same thing almost about 2 weeks less duration of benefit with a combination of estrogen, progesterone, testosterone as an injection. It's got to be in the buttock because it's just you need to have enough muscle mass to absorb this and keep it in place for about 10 to 12 weeks is what the patients are getting benefit. I'm up to 35 patients, and I'm happy to say that this has been a game changer for them. They're very happy with it. They don't have to rub the cream, worry about absorption and things like that. Many of them are able to come off their intravaginal therapies just because the systemic estradiol levels are good enough. So that's sort of an innovation that I'm doing right now. But even in those patients, they'll vary. The ones that are still kind of having irregular menstrual cycles sometimes will have that. But most of the patients, it regulates them so well that they stop having these sort of cyclical symptoms until the dose is wearing off. So to get kind of a long answer to, I think it's a receptor alteration. I think at varying times during the cycle, there's receptor alterations. We're going to find one day that this is genetic abnormalities and receptors and that those change in a hormonal environment. And so not only will a given receptor have a given genetic predisposition for having problems, it may be a different response at different levels of the cycle and different hormone levels in a woman's body. And that's the best answer I can give for that. It's an observation that indeed it happens.
It'd be an interesting area to do some more research in, given how many people do report that. And related to that topic is people who are on hormonal replacement therapy and say they react to the estrogen and that it seems to cause bladder symptoms. In that case, do you adjust treatment or do you think it's a matter of time before those kinds of symptoms dissipate?
I try to adjust treatment towards symptoms, and many times you're playing off side effects. In this case, obviously hair loss or where you don't want it, and hair growth where you don't want it. And that's a balance between estradiol and testosterone. You can almost always achieve that by dose adjustment. But for a lot of patients, they need more androgen to get their libido where they want it to be in their energy. But then that creates androgen side effects. And increase the estradiol, then it starts to cause the same symptoms that you are. So it can be a fine tuning. And I always say, look, I'm never going to get it perfect, but I'll get it right. That's what I say about when we try to do these hormonal adjustments.
And we do focus a lot on estrogen when it comes to hormonal therapy. How do you use
Mm-hmm.
testosterone or progesterone in that kind of
Mm-hmm.
approach?
So progesterone is highly controversial in my view. You have one school of thought. A lot of the functional medicine doctors and naturopaths, they feel like a woman needs progesterone. Progesterone is a critical hormone throughout life, although I'd say just like the others, it ebbs at menopause. In women that still have a uterus, I always use progesterone, obviously to keep from bleeding, to keep the endometrial lining, the lining layer of the uterus, minimal, and so it's not just stimulated, overstimulated, into kind of pre-malignant changes. So that's pretty much essential. But I try to use the lowest dose possible to achieve that and to regulate not bleeding and or having, if they're still cycling, to have not have heavy periods or long periods. Having said that, there are some women for whom things like sleep, if they have premenstrual migraines, those that are pretty much have anxiety. Anxiety is a big part of their symptomatology at various phases of their cycle. Then I will offer them more progesterone.
Mm-hmm.
But these women that are 200, 300, 400 milligrams of oral progesterone because they're getting pellets and their estradiol levels are still very low and their testosterone levels are through the roof, but they're symptomatic because this is raising your SHBG. 100% of my patients on any form of oral hormonal therapy are they're all of them has raised their SHBG. 100% have an elevation in their SHBG because of that. So you're poking holes in the bottom of the bucket that you're trying to fill, and it can make it very challenging. But it's also a very common source of referrals for me because they're not happy with how they're doing and they've heard about me. So the progesterone, I think, is something that's variable. For those providers that say it's essential and should be given, I would say yes, that's fine as long as you avoid the effect, which can be, I mean, it's also feeling less in your premenstrual syndrome. That's when progesterone surges. It's also a something that can cause weight gain and bloating. And to me, it's the essential factor in the sort of weight gain that women have experienced after starting hormone replacement therapy. But obviously that's very, very bothersome to women. Early on in my career, I found out what it means to change dress sizes when women would gain 5, 10, 15 pounds after hormone therapy. And I'm not, that's not an insensitive male comment. It's the reality of the fact that I did not recognize how much this impacted their weight. And weight is obviously something that we all need to work on and maintain a healthy weight. And anything that contributes needs to be looked at as a factor and altered as much as possible.
Definitely. And do you think progesterone could cause UTI symptoms in some people?
I do because it can be relatively hypo ovarian. In other words, it can, if you give progesterone or you give too much, it suppresses. Particularly if it's oral, it suppresses. Now you can get progesterone in cream. A lot of people feel like the topical progesterone is not as effective. They do all these fancy tests to see all the different progesterones and their metabolites and all that. I'm just a lot more simple than that with those issues. And I find that avoiding progesterone as much as you possibly can is the best alternative. And just letting the estrogen and testosterone, estradiol and testosterone be what you vary.
Some people do report issues with estrogen therapy too, especially vaginal therapy, especially like chronic yeast infection. And is that something that gets better over time with that kind of therapy, or do you have to also dial back the treatment?
In my view, it's very important to get proper compounding agents. A lot of patients, the standard pharmaceutically available agents are often not good for my patients simply because they're already had issues with vaginitis. They've already been on, they're already hormone depleted so much that it's just the agent, the carrier is what it's called, that they may be reacting to. Estrogen, any hormone, when you have a deficiency, looks like a foreign substance to our tissue. And you can react in an inflammatory pattern, in an inflammatory manner at first because the receptors don't know what to do with it. It's kind of passing into the tissues in very high concentrations. And again, it's a pro-inflammatory state when we have a deficiency and we treat. So the goal in those patients is to start with a very, very hypoallergenic base and use a very low concentration and a very small amount. Just say, like I was saying for the other, just to start with a quarter gram of 0.01% in a base that's very well tolerated by most patients, and then try that. Sometimes they're still very sensitive. There are a number of women for whom we just can't get it right. I can't figure out the combination or how to do it. Pretty much they're rare, perhaps 5% or fewer women where we just can never get the estrogen in the vagina to do what we want it to do. But I will tell you, almost all of them can tolerate Interosa. Almost all of them can tolerate the intravaginal DHEA. That seems to be whatever they're putting in those suppositories. If you get a good compounding pharmacist, seems to be something that's holding them, I should say, preventing them from having that kind of reaction.
Yeah, it's interesting. We did get a few questions about how to do dosing for suppositories or pessaries, depending which area of the world you're in. So some people have been told to use a hormonal pessary as well as a probiotic or a prebiotic pessary every day. So how do you use those if you have to use both every day? Can you use them at the same time, or do you have to separate them somehow?
I believe that those can be kept in place. I don't know that you need to remove the hormonal rings or hormonal pessaries and use the therapies. Theoretically, there could be some drug interaction that prevented absorption, but since these are indwelling typically and they have a sort of a slow release, it's very unlikely that you're going to impact the absorption of both agents. In other words, cause one to not let the other one be effective. Now, I don't have pharmacokinetic data on that. I don't have 2 or 3 papers to quote to say that that's the case. But from a practical standpoint, I will say one of the things that just, Melissa, it's just a lot of women come in and they're putting like 5 things in their vagina 3 times a week. And, you know, they're every minute of every day, they're thinking about putting something in their vagina. And it's got to be maddening to think that you have to focus that much on that part of your body just to be able to have a quality of life.
Yeah.
So what I try to do is I try to minimize that and see what's essential and what's not. How can we wean off something? Pretty much everything has got a term. I wouldn't call it short term, but you know, most things that I recommend don't need to be done more than 3 or 4 months in order to get efficacy, and then you wean off to see whether or not you still need it. So,
is that the same case with DHEA or Interosa?
So most of the patients have such refractory conditions that I'm reluctant to do that. Again, it's only been a year where I've really switched to intravaginal DHEA as kind of I wouldn't say go-to, but for all the patients that aren't tolerating estradiol or estriol or combinations intravaginally, I've gone to that. It's only been a year where I've done that. And so there aren't that many that can or have weaned off it to be able to give you a proper answer to that.
Okay. With the case of Interosa or vaginal DHEA, can you use that at the same time as a probiotic? A vaginal probiotic, I should say.
Yes. Can.
Okay. And last time in your interview, and we had this question a couple of times from people who watched the first interview, you mentioned a prescription probiotic and a vaginal prebiotic to use during antibiotic therapy, and people would ask you if you could share the name of that.
So not to be teasing or to be coy. Actually, a lot has evolved since that time. And one of the things that evolved is that the standard generic proprietary brands you can get at multiple chain pharmacies in the United States, not abroad, but in the United States, the CVS's, Walgreens, they typically all have their proprietary brands of prebiotics and probiotics that are actually very good. They're encapsulated. They're enteric coated. They are multiple organisms and very high counts, such that you're getting really for a very, it's a cost factor. In order to get those, they typically were very expensive and didn't have the greatest shelf life. So now in the US, I'm converted and tell all the patients just go to Walgreens and get their best proprietary brand out there that's got the most organisms and the most colony counts to be able to use. And that's been as effective as any, particularly from a standpoint of the patients that really are going to be on long-term antibiotics. That's been essential. Okay. So I'm not teasing. It's just that this has kind of changed.
Yeah, it's a good update. It's been a few years since we last spoke. You also mentioned in that first interview that you have an information sheet that you share with patients about vaginal health, and we had a few requests about whether you could share that with our community.
That's going to have to be something that's going to be, you're going to have to update, because I don't really have that in a form right now. I'm working on that. I hope to get that out soon, but hopefully that will be updated, and you can put that on your website as soon as I come up with it.
Yeah, that would be great. Before we move on to UTIs and sex, which is a topic that we have covered previously, we did have a question about whether there's an association between UTIs and hormones for males.
UTIs and hormones for males. We guys get so lucky with this. We have so many more asymptomatic. Most of the time, we're the asymptomatic carrier that's causing the infection, as opposed to suffering from this. But there really doesn't seem to be, even our patients, for instance, that are on this testosterone depleting therapies for prostate cancer, that doesn't seem to predispose them to more chronic prostatitis or chronic UTIs. In men, I will point out that when there's an infection, I'm convinced it's everywhere. The classic for women is women are getting chronic UTIs. Well, most of the time they're cystitis. In men, when we get an infection, it goes all over the male ductal system, the prostate, the bladder. So that's why more aggressive treatment needs to be done to eradicate those. But they do seem to be spared the hormonal depletion issue.
Thanks so much for watching. I hope you found part 1 of this interview helpful, as we explored the impact of hormonal imbalances pre-menopause and how treatment may help reduce the frequency of UTI. If you'd like to learn more about this or related topics, be sure to check out our other videos or head over to liveUTIfree.com for related articles. And don't forget to watch Dr. Hlavinka's first interview. We'll add some links in the description. Of course, if you like what we're doing on this channel, be sure to hit subscribe and tick the bell so you'll be notified of our future videos. Thanks so much for watching, and until next time, keep asking questions and pushing for better solutions.